Hello, Holistic. This is the second part of cancer pain interventions. Um, we're going to talk about neurosurgical interventions in this. And basically, neurosurgical interventions in cancer pain is classified into three categories: anatomic, such as tumor resection; augmentative, such as dorsal column stimulation, which is less used than the intrathecal drug delivery systems; vertebroplasty and kyphoplasty; or ablative, such as dorsal root entry zone lesioning, midline myelotomy, percutaneous chordotomy, and cingulotomy. And you can see the different sites of, uh, you know, um, procedures. Like, for example, this is for chordotomy, this is for myelotomy, this is for the DRES, and so forth. So we'll start with the intrathecal drug delivery system, which is really one of the most important methods to treat intractable cancer pain. For patients less than life expectancy less than 3 to 6 months, you can use the externalized system or the partially externalized system, like the DUPAN or the Portacath systems. While if you have a patient that probably will, live beyond 3 to 6 months, it would be very wise to use the intrathecal systems, the programmable intrathecal systems. Now, these systems are very sophisticated, and they have, um, you know, they can provide the patient with different type of flows. Like, it can give you constant flow, it can give you demand boluses, it can give you a periodic flow, and it can also, you can program it to multiple rates, which actually translates to a lot of flexibility to different patients. Okay. And of course, it's reflected on the price of these machines as well. So we'll start with the DuPen and the Portacath. I prefer the Portacath because it's the site is covered with the skin, while with the DuPen, um, the catheter comes out of the skin. Anyway, I mean, whatever you like to do, it doesn't matter, um, because this is really used in limited lifespan, okay, or patients with less than 3 to 6 months. All right, I can tell you that the Portacath is more frequently used. And of course, you have to access the sport like exactly the Portacath you use in, when you're doing chemotherapy. You have to use a certain needle called the Huber needle. Um, so it needs some training, okay? Usually the nurse would take care of it and she will, do the infusion for the patient and so forth. Programmable pumps, these are, as I said, super sophisticated and expensive machines. They are implanted in the abdomen or the in the buttock area, away from the sciatic nerve. And the catheter is threaded intrathecally to around T11. Okay, and there is a reason beyond doing this, and the reason is that has to do with the CSF mechanics here. This is the best spot for the tip of the catheter, no matter what type of tumor you're dealing with. Okay, you still need to threaded to the T11 area. Now, the pump here has is a reservoir port, and it has also an access port. The reservoir port is the port where put your medications in. And most pumps, has a volume of around 20 cc's. Okay, the access port is a port that's on the side. We use it only in emergency to make sure that the catheter is patent. Okay, and I want to say that we use this Huber needle to access this pump here. Now, why are we using intrathecal pumps? If you think about it, morphine orally, 300 milligram oral morphine, if you translate it to intrathecal morphine, it's only 1 milligram. So the main indication of these pumps is when you're having a lot of side effects from the oral or even the parenteral opioids, then you probably going to need this pump. Like patient cannot tolerate these medications, then you have to use it, intrathecally. These pumps comes with its complications, and we can divide these complications to three types: pump-associated problems like battery depletion, under infusion, over infusion, inability to access the reservoir, and difficulty to access the side ports. Now, I had this complication of inability to access the reservoir one time, and literally, patient had withdrawal symptoms, and really, we had to deal with him inside the intensive care until the neurosurgeon came and he adjusted, the pump. It was kind of, it was flipped. Patient had a lot of, free adipose tissue under the skin, and the pump was flipped, so he had to return it back and do some suturing and all that. Pocket associated problems. This is also another issue with these pumps. I've seen seromas a lot. And literally, whenever we do a pump, you have to provide the patient with an abdominal binder to help reduce the incidence of seromas. Beside the seromas, you have hematomas and capsule formation. Lastly, is the catheter associated problems, such as granuloma, a kink, disconnection, hole or a tear, fibrosis, or migration. I want to talk a little bit about the granuloma, okay? Because really it's interesting. I was lucky to pick up 2 cases of intrathecal granuloma in my clinical experience here. These granulomas are at the tip of the catheter, and they're basically a kind of a sterile inflammation, secondary to irritation by the high concentration of opioids, especially morphine and hydromorphone. Fentanyl doesn't do that. Okay, clonidine doesn't do that. So just give you an idea that not all the drugs cause this irritation. There are certain drugs, and they have to be in a very high concentration. So if you're using morphine, for example, they're recommending you not to go beyond 20 milligram per ml. While if you're using hydromorphone, they recommend you not to go beyond 10 milligram per ml, just to help with reducing the incidence of this irritation. So how do you pick it up? Usually these patients will describe, some weakness in their legs. They're getting somewhat ataxic. They have possibly paresthesias in their lower extremities. And then also the efficacy of the pump goes down because the CSF is blocked, so it doesn't reach all the areas that's causing the pain. Um, Also, when you go and examine these patients, do a knee reflex because usually the knee reflexes are exaggerated because of the pressure on the spinal cord. This is out of Medtronic. Some numbers here to think about. Catheter complications from three Medtronic-sponsored clinical studies. The commonest one is the dislodgement and migration. Next to it is the fracture and the break. And then you have all kinds of, kink and occlusion next to that, and then cut and puncture. Okay, so what medications are we going to use in the pump? I'm going to try to summarize it to you in just a few sentences. There are tons of medications, okay, that can be used intrathecally, but there are the only FDA approved drugs in the pump are three drugs. The ziconotide, which is a calcium channel blocker, and we use it for mainly for non-cancer pain, a neuropathic non-cancer. All right, this a medication is extracted from a certain snail. Okay, it's called Conus magus, and it's actually abundant in the Red Sea. Uh, and then you have the morphine. All right, morphine is FDA approved to be used in these pumps, and this is used mainly in cancer pain. Okay, number three is baclofen, and baclofen is used mainly in spasticity, like cerebral palsy patients or spinal cord injury patients. So these are the main three drugs, and this gives you a hint right away to the indications of these pumps. Nowadays, the pumps are used less in non-cancer pain and used more in cancer pain, okay? And also in spasticity. So the main two indications of intrathecal pumps are cancer pain or intractable cancer pain that's now responding to other modalities here, and spasticity. Non-cancer pain is getting out of favor, but still a lot of physicians still use it, okay, especially in difficult cases. And then they do this, conferences every few years. I think this is the lost version of this conference. And basically, here you see ziconotide and morphine are on the top. And this is basically for pain. If you have a spasticity, of course, you will be using baclofen. Then line 1B would be hydromorphone, okay? Or you can add bupivacaine. Line 2, you can add clonidine, and so forth. Or you can do a mix between morphine and ziconotide. So you have really, all kind of cocktails can be done, and depends on the operator preference, what to use and what not to use. All right, we're going to talk about percutaneous vertebroplasty. This is a procedure that we use mainly for osteoporotic compression fractures, but it could be used also for cancer pain in patients with malignant destruction of the vertebrae, painful aggressive hemangiomas, or even painful vertebral fractures associated with osteonecrosis. Now, you guys know that with these with the compression fractures, we love to use these IV bisphosphonates, such as zoledronic acid because it really reduces the pain and decreases the rate of skeletal complications. Now, when you inject the material inside, which is basically cement, inside the vertebral body, you create like a thermic reaction that will basically attack the small nerve fibers inside the vertebral body, and this will reduce the pain quite a bit. Besides, it creates some sort of a stabilization of these vertebral bodies, and thus it will help with also the pain induced by the compression fracture here. Um, so this is how we do the vertebroplasty. We use two needles, and we go basically inside the vertebral body and inject cement. Of course, this procedure cannot be done if there is a pressure on the spinal cord, right? Because if you're injecting cement, you might leak to the spinal cord, all right? So you have to really look up the MRI before you put your needles in and make sure that you're in the right spot when you do the cement injection here. Now, there's another one that similar to the vertebroplasty called kyphoplasty. And in this operation, basically, we create a vacuum inside the vertebral body. One of the techniques is using a balloon, okay, that, we inflate it inside the vertebral body. Uh, the, uh, the importance of doing this void, is to restore the height of the vertebral body, okay, which you lose after the compression fracture. And of course, once you do the void, you deflate the balloon and then you inject the semen. Percutaneous gray ramus communicans blocks. All right. These are actually old techniques that we used to use in cancer pain before the era of these vertebroplasty and kyphoplasty and all that, which actually was basically discovered in the late 90s by a group of interventional radiologists in France. So we block this nerve, okay, called the gray ramus communicans. Nowadays, it has some indications, like, for example, if you're not able to do the vertebroplasty, okay, you can try the gray ramus communicans injection, or if you have a failed vertebral augmentation, then you can actually do this block here, and then you do the radio frequency after that ablation if it does work. Okay, we'll jump into a procedure called a percutaneous cordotomy. And percutaneous cordotomy, guys, is basically getting a lot of momentum in Europe here after a major study in Liverpool where they did a lot of end of life kind of patients with intractable type of cancer pains, and they really had very good results with very low complication rates. Main indications of this procedure is basically intractable uh, pain, usually cancer pain, unilateral and below C5, with a life expectancy less than 1 year. Okay. Um, Now, if you do, with this procedure, we try to ablate the anterolateral spinal thalamic tracts. There are multiple complications that can happen. but really life-threatening complications occurs in less than 1%, especially if you're doing it bilaterally. So try to avoid doing this procedure bilaterally because you can attack the reticular formation that's responsible for breathing, and you will end with something called central apnea or undying curse, okay, where the patient will not be able to breathe unless you order him to do so. So unfortunately, with these patients, you have to put them basically on a ventilator. Here's the picture here of the anterolateral spinothalamic tract. Here's the reticular fibers. Look at it, just next to the anterolateral spinothalamic tract. So if you do it bilaterally, you can damage these reticular fibers. And then you have, of course, you can cause motor weakness. You see this corticospinal tract here. If it's get damaged, you can actually cause, weakness, motor weakness. Uh, the needle should be in front of a ligament here called the dentate ligament. And you can delineate this ligament with your contrast here. So you need to be anterior to this dentate ligament. Because if you go behind it, you'll basically stick the needle inside the pyramidal tract here, corticospinal tract. Okay, this is how they do it, C1, C2. And in fact, actually, the commonest complication encountered with percutaneous cordotomies are dysplasias. Okay, cingulotomy, stereotactic cingulotomy, is another interventional procedure, uh, usually done by surgeons, neurosurgeons. We call them the functional neurosurgeons. And by the way, these guys are not really abundant in the world as you guys might think. There are very few of them here, and there. So you need to ask, in your institution about these folks here, whether they're available or not, and whether they ready to do these types of procedures. So anyway, the stereotactic cingulotomy is used when you have diffused metastatic pain, and on top of this, you have a huge emotional, you know, component to the pain. Because as you know, the cingulate gyrus is basically responsible for the emotional aspect of the pain here. Okay. Uh, and then we have another nice procedure called dorsal mylotomy. So this is a very important anatomic fact here, guys. The visceral fibers, whether thoracic or abdominal or vertebral, they actually reach the thalamus through the posterior column, not through the anterolateral spinothalamic tract. So if you ablate the midline here, you'll be ablating these visceral fibers. So this procedure is really very important in patients with intractable abdominal and pelvic visceral pain. This is the dorsal mylotomy here. Look at going with the needle. Of course, again, this is done by neurosurgeons, okay, qualified to do these procedures, what we call functional neurosurgeons. DRES, or dorsal root entry zone lesion, this is basically indicated in post-amputation pain, pancreas tumor, radiation-induced plexopathies, and brachial plexus avulsion. Nice thing here that this procedure can be done also in intractable trigeminal neuralgia. uh, that's not responding to the conventional procedures like radio frequency or balloon pressure or glycerol or whatever. You can do something called codalis dress, where you attack the caudal aspect of the trigeminal ganglion here, the spinal part. Now, with this procedure, you might, have some complications. And again, the main complications are sensory, like ataxia, hyposthesia, and dysesthesias. Okay? Sometimes you will have motor complications, but mainly because we're actually targeting the dorsal root entry zone lesioning that's away from the motor fiber. So usually the complications here are sensory in nature. Okay. Thalamotomy is another procedure that we use for extensive nociceptive pain. And sometimes we use it in neuropathic pain with surface allodynia and hyperpath. So we're going to wrap up this lecture about intervention cancer pain by mentioning that, that the WHO recommendations, they really stress on, treating cancer pain because it's still a huge and major problem. Now, the nice thing is that we can deal with 90% of these patients with pharmacologic agents. And what I mean by pharmacologic agents are basically opioids. All right. So the ones that don't respond well to pharmacologic agents, the 10% are the one that needs to get, interventions and stuff like that, like we're talking about. So it's not everyone. I mean, probably you will be able to cover 90% of your patients with the proper opioids. Uh, the cancer pain management is both multimodal and multidisciplinary. Multimodal that in a sense that you have to use more than one agent. A multidisciplinary is that you have to involve more than one specialty here. Again, don't forget about total pain, okay? And this is the term coined by Cicely Saunders here. And, you have to understand the meaning of total pain in the context of a cancer patient. The pain is not only somatic or physical, it's also psychological. It could be social, emotional, or even spiritual. Okay, thank you so much for your attention. Hope you enjoyed the lecture here. We'll see you another presentation. So, thank you.